PMS. We all know what that stands for, and so do those around us. But what if, leading up to that time of the month, you're suffering from panic attacks, mood swings, frequent crying, anxiety, despair, or even thoughts of suicide? Enter premenstrual dysphoric disorder, otherwise known as PMDD. It is a cyclical, hormone-based mood disorder, but is not a hormone imbalance. In fact, it is a severe negative reaction in the brain. To better understand this condition, I sat down with Laura Murphy of the International Association of Premenstrual Disorders, and Laura shares with us her story as well as how to get properly diagnosed and treated for this condition. And as you can imagine, it must be incredibly difficult to live with. And so if this is you or you know of someone who might benefit from this episode, I really would appreciate you sharing it because Laura shares such incredible, valuable information. So let's hear from Laura.
PMDD stands for premenstrual dysphoric disorder. It's a hormone-based mood disorder which affects around 1 in 20 women and those assigned female at birth. It's a severe form of PMS. The symptoms only occur in the time between ovulation and around the time of your period. So people will often complain of PMS that makes them feel suicidal, or perhaps they're diagnosed with bipolar, that rapid cycling bipolar that kind of comes and goes. We often see people as well who have children or a child or a miscarriage, they have a pregnancy, who then are diagnosed with postnatal depression, and that depression kind of keeps coming and going in waves, and no one can kind of pick up the timing exactly, the fact that it's, you know, the symptoms are ending around the time of menstruation. And I have to say it affects everyone differently. There are diagnostic criteria, but we're really noticing, you know, how limiting they are, despite the fact, you know, we need those classifications for order, I guess. But main symptoms include depression, anxiety, feeling of being overwhelmed, changes in eating habits, so perhaps completely losing your appetite or overeating, craving certain types of food, panic attacks, suicidal thoughts for some people. Some people get rage and anxiety, not everyone does. And some people also get physical symptoms such as bloating. Leg pain seems to be one that comes up a lot, or leg heaviness. Changes in sleeping habits. So some people get insomnia. I used to get hypersomnia, which meant however much I slept, it never stopped the fatigue. You know, I'd sleep 18, 19 hours a day and couldn't keep my eyes open. But all of those symptoms for PMDD are contained within that luteal period, so between ovulation and around the time of your menstruation. So some people, it goes the whole 2 weeks through if you're on a 28-day cycle. For other people, they may feel worse around the time of ovulation, and then it picks up a bit, and then maybe they go downhill near their period, and all kinds of different routines within that 2 weeks for people.
So Laura, now that we better understand why I wanted to reach out to IAPMD, why don't you share your story and experience and kind of the role you play, and then we can get into the science and better understanding how to deal with this condition that can probably be so overwhelming, sad, frustrating. I think every emotion in the book is there. So please share.
Yeah, sure. So my symptoms really started about the age of 16. I did start having symptoms. I had quite a long depressive episode when I was 16, and I was asked to leave school. Times were very different back then. There was no support. I was just asked to leave because I wasn't turning up. I wasn't getting involved. I wasn't committing to it. I didn't really want to be there, to be honest. That didn't help. But when I was 17, I took the contraceptive pill for heavy periods, and after day 21, when I skipped to the sugar pills, I kind of crashed and burnt really. Like, my life really changed forever on that day. You know, I was on the floor, hyperventilating. My first sort of full-on panic attacks I think, just crying and sobbing. And then I went into a 6-month-long depression. And then for the next sort of few years, it's a bit blurry, really, because I'm 42 now. So that was when I was 17. But then from then on in, I had longer periods of depression. I also knew I had very bad PMS. It was a bit of a running joke in my with my female housemates at university that I could be a bit scary when I had PMS. But it was kind of like a long-standing joke rather than a concern. When I lived with my partner after university, he said to me once, it's like living with a different person for a week, a month. And I remember that so clearly because I don't think I'd really pinned down depression and panic disorder, which I was diagnosed with at the time. Let's pop the Marina in, it was sold to me as an utter godsend, it will sort everything out. And it did help for a little while. I had no periods. I went and backpacked. I think sort of the progesterone's built up in my system somehow. And I just had an almighty crash where I had what was basically PMDD symptoms for 18 months straight. I was suicidal every day. I couldn't work. I had to give up work. It was probably one of the worst times of my life. And, at that time, you're going back a few years now, I was Googling, Marina depression and finding, some things coming up on forums. I'm making myself sound really old now. Oh my goodness. But, I was finding these things coming up and I was going to my doctor, my GP and saying, I think it might be linked. I think all of this, because she'd been really good actually and been leading me through the devastation. I was told, no, the hormones in the Marina can't do that. It doesn't travel outside your uterus. It's all very contained. It can't do that. Don't believe everything you read on the internet. And it was kind of through those appointments I was actually having with my therapist at the time. I paid privately to have therapy weekly, and she was amazing, absolutely amazing woman. And it was her that kind of said, this isn't PMS like your doctor is saying. Your doctor might just be saying this is PMS and you need to suck it up like every person. But this isn't it. I started a patient awareness campaign, vicious cycle, because, everyone was saying the same thing. I'm going to my doctor. They don't know what it is. I've been undiagnosed for 10 years, 15 years, 20 years. For me, it was 17 years undiagnosed. People were going to their doctors, they're being gaslit, they're being turned away. So we started this patient-led campaign, vicious cycle. And through that, I just connected with so many amazing people around the world. I found out about an amazing doctor in London, Dr. Panay, who's now on IAPMD Clinical Advisory Board. We got him in. He's amazing. So on a sort of medical level, through him, it turns out, I'd already gone through some of the first line treatments. So we decided to remove my ovaries. So I had a total hysterectomy with bilateral oophorectomy. So I was in surgical menopause at the age of 37. And around the same time I was working with Vicious Cycle, I began sort of communicating with IAPMD, social media, tagging them in on things, using their website a lot, really helpful website. And I ended up joining the board of directors. And from that, I then started helping out on social media. It's still a relatively new organization then. We're going back 5 years now. Started helping out social media. Then I started acting as a social media coordinator, then social media manager, and now I'm the Director of Education and Awareness for IAPMD. Really exciting that I get to help other people who are going through what I went through and, like you say, help provide resources that are understood by patients and useful for patients.
What a story. And I am really sorry for everything that you have had to go through. And I just appreciate the courage that you have to continue to help other women. As someone who
Thank you.
struggled with infertility and endo, I know that it's so helpful to help others, but sometimes, some days it can be triggering. And I think when you and I got to know each other, we talked about that and giving ourselves permission of, this is triggering, I need to take a break.
Most definitely. And I think so many people within IAPMD are cycling or are post-op for PMDD and PME. So we're very understanding, and I don't really like the phrase self-care. It's completely okay to take responsibility for how you're feeling. And if you're finding something too difficult or too triggering or emotional, we make it very okay for people to step back and have their own time, which is quite unique. And I have to say, I don't feel very brave sharing the story, because I used to think it was very unique. And now I don't. I speak to people all day, every day, who are going through exactly the same thing. There's nothing really special about it. It's there's so many of us that are on that kind of difficult path, kind of weaving through and trying to get a diagnosis and trying to find the treatment and trying to find the answers.
Well, I would say that I don't think one of the descriptions of being brave is that it has to be unique. So,
well, I guess so. But
so why don't we talk about, like, first the diagnostic criteria? And I think this is important because, look, I will say some of the things you described, I hear about even like endometriosis, and in some cases with, Hashimoto's and other conditions. I'd be curious how you were finally able to get this specific diagnosis, and then we can talk about the treatments. And I do want to cover both evidence-based and the non-evidence-based, and how women should assess those for their own personal use.
PMDD is very on and off. It's literally tends to be, like a light switch for people, or that's perhaps not entirely accurate, but like a fade for people. So you have your follicular phase where you feel great, you feel normal, whatever normal is, you feel good in yourself, you're functioning and you're doing okay. And then when ovulation hits, it's a point where, it's a tipping point where things tend to get very dark for people, or people get very anxious, very ragey, and then when the bleeding stops, people describe it often as like a black cloud lifting. And that's exactly how I used to feel. I remember sitting on the toilet and seeing blood, and within 2 hours, just literally feeling like this kind of veil of weight had just lifted from me. And with PMDD, like the symptoms are predominantly psychological. Some people will have physical pain. It's not related to heavy periods. It's not related to period pains. It's an issue in the brain. People with PMDD, it's been shown from research, they have a genetic malfunction in the brain where the brain cannot handle the normal hormone fluctuations of the sex hormones that occurs in the luteal phase every month. So the brain has an abnormal negative reaction to the normal hormone fluctuations, where those fluctuations, major fluctuations, are only occurring between ovulation and menstruation. That is when the symptoms occur. Predominantly psychological. Often it's misdiagnosed as bipolar, rapid cycling bipolar. There are physical symptoms, but they're not period pains or heavy period pains or stabbing. It's classified as a mental health disorder rather than a gynecological disorder. But this is where it gets confusing. So it's in the DSM-5 as a mental health disorder, psychiatric disorder. In 2019, I think it was, PMDD was added to the ICD-11, so the International Classification of Diseases, making it a worldwide international diagnosis, which is amazing, because now hopefully it will start to be tracked. Yes, so in the ICD-11, it's listed as a genourinary condition with a cross-reference to depressive disorders, which is interesting but confusing, because it makes perhaps people think that it's related to heavy periods or bad periods, period pain. It's not.
How does someone truly diagnose it, though? Are there elements of blood work? Is there like a some sort of an actual test?
What tends to happen is that blood tests are done to rule out other conditions, so a hormone imbalance, thyroid condition, etc., which is often a problem because for practitioners that don't know about PMDD, it's okay, well, your hormones will come back normal, so off you go, where it's not an imbalance, it's currently not picked up in blood tests. So what is currently used for diagnosis is historical tracking, so a minimum of 2 months, really careful tracking of your daily symptoms, hopefully speaking to a provider that understands PMDD and can see, you know, the clear pattern that PMDD exhibits and pick up, you know, because there's also confusingly premenstrual exacerbation, PME. So that would be someone, for example, that suffered with depression for however long periods they lived with it for, you know, 4 months, 5 months, 6 months longer. So they would have symptoms all month round, but in the luteal phase, coming up to their period, their symptoms would worsen. And that can be the case for many disorders. So arthritis, ADHD, OCD, bipolar. So it can be kind of hard to pick up the two. So we would always recommend people see a provider that understands the conditions and can kind of pick apart that data, that information that you've prepared for them.
Right. So to summarize, what I'm hearing is that it's almost a diagnosis by exclusion of other conditions.
Yeah, by ruling it out, but also seeing that the patterns you're exhibiting match the condition well, that kind of on-off.
Why do people get it? Who gets it? So you mentioned a genetic condition. You're saying there isn't a biomarker, but they're saying it's about genetics. So I guess how do they know that? And are there other themes that could predispose somebody to have this condition?
So there was research done research that was published in 2017, where they had shown that they'd found the genetic malfunction. They'd compared white blood cells between those who had PMDD and those that didn't, and they found a difference in the pathways of people's hormonal regulation in the brain during the luteal phase. There has been some research done about trauma in childhood. That seems to be a very common factor. Any different kind of trauma, neglect, sexual abuse, there seems to be like quite a high prevalence in the PMDD community, but that's not, that doesn't go for everyone. But we do know it's hereditary. We do see lots of people whose parents have had it and then whose mother's side had it. We hear many stories of people whose grandmothers, were sectioned during their menopausal years.
Does it get worse in menopause?
So in terms of PMDD, some people have it from their first period.
Okay.
Some people, like myself, get it through some kind of, or have the symptoms triggered by some kind of hormonal interruption. So that could be, some people may just have, no symptoms or PMS-like symptoms until they have a pregnancy. Some people find that it worsens with each child if they have more than one child. Some people, it can be a termination, a miscarriage. It can be taking a certain type of medication. It can be a stressful event. It's not quite fully understood why it gets triggered along the reproductive pathway, but not everyone has it from a teenager. It's common, but not everyone does. Certainly, we see people where the hormones start jumping up and down faster during perimenopause. We definitely do see people struggling more in that period. I wouldn't say it gets worse for everyone in that time, because sometimes people respond really well to hormone replacement therapy.
I'm listening to you and I'm like, do I have PMDD? So I'm now going to do research and start tracking. Like, I almost want to cry. Holy cow. Okay. So I will keep going and turn on my podcast host face. A lot of my friends who are in perimenopause, like, I've been attributing it to it. But when you're saying like, if this really got exacerbated after I had my son, wow. Like, I'm kind of in shock right now. I'm really interested in the solutions here. I mean, we have this condition that has a label that is defined. So what are solutions. And I mean, I'm almost scared to ask because there's so many ifs, ands, and buts in everything that you've said today that I can't even begin to figure out how doctors without the clinical research can put the pieces together in helping women. So as best as you can, I'd love to hear those treatments. And you had mentioned in your story there are tiers, so maybe you can walk through it in the tiers.
Of course, yeah. And I can supply web links and stuff. We have treatment algorithms and all sorts to share. First of all, I have to say there's no one size fits all. It is trial and error. The best or the most effective treatment we currently have for PMDD is SSRIs. So they work really well for approximately 60 to 70% of people. Again, it can be trial and error. So some people take them all month round. Some people take them for the 2 weeks a month, and other people can use them just when symptoms are present. So they work differently for PMDD than they do depression. So they don't take, the 2 weeks to kick in as we're told. So they do work differently, but they do work really well for a lot of people. Again, not everyone. Sometimes, people have side effects that, aren't worth the payoff, but that would be the first thing that a doctor with knowledge of evidence-based treatments for PMDD would start with. There's also the contraceptive pill. There's a certain type of contraceptive pill. I think Yasmin in America is the only one licensed for treatment of PMDD. So for PMDD, the idea is, complete cycle suppression. So you don't take the sugar pills, you just take the pills back to back, no bleed, no fluctuations, literally just keeping that cycle suppressed the whole time. And again, that works well for quite a lot of people. Some people find that they do better on different pills. Some of us, like myself, I couldn't tolerate any of the contraceptive pills. They all made me kind of go off the charts mentally. But some people do really well, and some people, they use both. For perimenopause, I think it's a bit different. I know we're just launching a page on PMDD and menopause, and I know one of the things I read was that HRT can be really, really useful. It can kick in quite quickly for people in perimenopause with PMDD. Along the lines of cycle suppression, so in the UK, it's not as common in the USA, but in the UK we have official treatment guidelines from the Royal College of Gynaes and Obstetricians. So we have guidelines here, not yet in America, sadly, or Canada.
So, I mean, even though the technical guidelines aren't listed, would you advise women review the guidelines that I assume are posted on your website and read through them and use that as a guide to have conversations with their clinicians?
Anyone with PMDD should print off everything they can get their hands on. Okay. On the IAPMD website, we have a free download for professionals of the algorithm. We are just launching actually in the next, I think it should be in the next few weeks, a patient or walkthrough of treatment. So there'll be an algorithm and then there'll be a breakdown of each of the treatments, what to expect, how many people it works for, efficiency, what are the potential side effects, when do you know when to stop?
How quickly should something work, and does it depend?
It depends on the treatment. Okay. So for example, SSRIs, I believe, work pretty quickly for those with PMDD. But again, that's if you get the right dose straight away and you get the right type of SSRI. Okay. Things like hormone therapy and hormone replacement therapy can be really, really difficult for those with PMDD because you're having a surge into your system. And if you're very sensitive to any changes, so for example, as I was saying, in the UK, there's like another step, hormone suppression using HRT. So where they, instead of using the pill to suppress that cycle, they use HRT methods, so patches, gels, etc., with an add back. Starting that, the first 4 weeks of starting that can be very challenging for patients.
Are there things that you're seeing, whether it's on social media, the women that you're working with, that, again, I almost feel awkward even saying that aren't proven methodology because it seems like there's so little we even understand here. So I would say the things you've mentioned are proven in the sense that there are trials before a lot of these medications are released. How much we know for PMDD specifically seems to be somewhat debatable. So I will admit this is a strange question, but have you seen things that women have tried that maybe are surprising, not as clinically proven as prescription drugs, that either you want to caution women about or just mention and just clarify that it hasn't been proven? Like, is there anything else? Because I know as someone, when you're desperate, you'll do anything. And I think it's important, especially with social media and so much being promoted without necessarily having a medical background. I think it's important to know what your organization has been seeing and what women need to know.
We are not the PMDD police. We're not going to tell people what to do. We want to inform people with evidence-based resources. That is what I don't even want to say promote. That is what we share. We don't, we're not going to tell people what we think they shouldn't and shouldn't try. We're there to put the information together and push for better research.
Right.
And, just better inform them and help them on that journey through the treatments that are currently available.
Okay.
I don't think there's necessarily anything we'd warn people of. We'd always say to people, be very mindful of who you're seeing as a provider. I personally would be very wary of anyone that offered a cure. There's plenty of people popping up on social media now, that can cure your PMDD. I would very carefully check their credentials and their training before moving forward with it. Interestingly, so this is something that came up. We just did the world's first PMDD community coalition, which was really exciting, a roundtable back in July. And for that, we formed a patient insight panel. And something that came up as an area of interest for research was antihistamines spread across the groups. And I think the only other thing I would say is just know your own body. I kind of realized after I had the Marina out and after I did lots of reading that lots of people with PMDD have progesterone intolerance. So they have a hard time and react negatively to progesterone-based treatments. I would say just know your body, that's not the case for everyone with PMDD. Some people react really well to it. There's just a high prevalence. I would just say, know your body if something isn't working for you.
I've been hearing so much about food triggers. There's meditation, yoga, tapping techniques, and there's such a mental health component. And again, I know everyone is different. Have you seen themes of things like that potentially also helping people as additive benefits? They're certainly not harmful, right?
Anything that's stress reducing is going to help people. Stress will make PMDD worse.
Okay.
So managing your time, managing your stress levels, bringing those cortisol levels down, all of those things are going to help. They're tools in managing the condition.
We'd love to give a glory story at the end of this podcast and say, if you do this, magic, you're healed. It sounds like this is a reality check where what I'm hearing is there's ways to help. There are resources where there's a community. You have tons of stuff on your website that I saw, and there are ways to manage it. And perhaps by speaking up about it and being informed, we as women can help doctors by talking to them about it and by working with your organization to help elevate the noise, so to speak. Because you even also have a list of doctors, I believe, on your website who specialize.
We have a provider directory of doctors who've been recommended by patients. So doctors can't add themselves. It's all people that have seen them and rate them on how helpful they were or not.
So what would you say then is your greatest hope? And you could speak about PMDD or women's health in general.
Oh, wow, that's a big question. I would say, in terms of PMDD, it's already starting to happen. It's really exciting. So like I said, we just had the PMDD roundtable in July, bringing together patient voices and professionals. So we had research scientists, advocates, clinicians, policy leaders. There just needs to be movement, positive movement in the right direction, early detection, for people so they have education, so they don't have years wasted thinking it's something that's their fault, or they're just not strong enough, they're not able to cope with life like other people, because that's how I felt. I couldn't hold down a job, I struggled with relationships, my behavior would go a bit haywire very often. And I think early detection for patients, that comes through awareness, and that comes through provider education. So we've just started a clinical practice community where people can come for monthly webinars and learn more about it, and they can network with other people, network with other clinicians and scientists. Growing IAPMD, so we can really, dig our heels in and get involved and make a better future for people. That's our tagline: creating a world where people can not only survive, but they can thrive.
That's great.
Like you say, I wish, I also don't want it to be the voice of doom and gloom. I know plenty of people that have been diagnosed and started a treatment and done really well, and off they go, they disappear, they go and live their life. And it doesn't have to be a life sentence. There's plenty of us that unfortunately haven't reacted to the treatment, haven't responded to the treatment that's currently available, and had to have surgery. But that is very much the end of the road for people. It's not like the go-to route. I think people panic a bit. They think hysterectomy is the cure, and there's so many things to try before then. But I think just be comforted that there's a really amazing community around the world of people who will listen and understand and help you.
No, it sounds like it. Well, Laura, I really appreciate you sharing your story, and again, working with this organization and helping it elevate its voice, because I do see a lot of posts about PMDD, and I know I learned a ton today, and just really appreciate the efforts, and keep at it. I mean, women's health is getting more and more recognition, and the more we talk, the more people listen, and hopefully it generates more research dollars. So thank you again.
We're a small organization, but we are mighty and very loud.
Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find the link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.